Excited to have Dr. Embley here with us. He's got some really cool experience to share, and I'm excited myself to learn more about the rural medicine track, as I know a lot of our prospective students are. We've had a lot of questions coming in, a lot of students interested in doing rural medicine and wanting to learn more about kind of what that track entails and what rural medicine really is. So we're excited to have Dr. Embley here with us. Dr. Embley, I'll let you go ahead and introduce yourself a little bit and then take it away.
Thank you. I'm happy to be here today and love talking about rural medicine. So happy to talk about that or anything else that comes up with respect to Noorda and the school here. And clinical medicine is a passion of mine. I was originally trained as a family medicine physician, and my first job out of residency was definitely rural medicine. It was a small town in central Utah. Had some other great physicians around me, thank heavens, but a small little community hospital. So that's where I spent a great deal of my formative years as a physician and loved the experience. It's amazing what it can do. And I'm happy to be able to, as part of my responsibilities as the chair of clinical sciences here at Noorda, I'm responsible currently also for the rural tract that we're trying to provide for the students and the elements therein. I also had some experience working, I guess I would call it more of a suburban-ish area, but one of the things that I'll talk about during my experience is that really anything rural can be something that doesn't have specialists around you because you have to sort of take care of things yourself and take care of the patients in your own way. But be glad to share a few experiences as we go along here. Let me start off by first kind of describing just the simple basics of what a track means here at Noorda with respect to what does that even mean. So what it means is essentially that you have an interest, and that doesn't mean you're committed to go do it, but that you have an interest in learning about rural medicine. It involves a few different steps during your first couple of years when we're doing basically biomedical sciences and sort of the on-campus portion of your education. It does involve taking a couple, essentially 2 of the 5 offered elective courses that match up with the rural tract. And let me just describe what those mean a little bit. One of the classes, for instance, is just an ultrasound that takes you a little deeper into ultrasound emphasis, because that's a tool that can be used a lot more in a rural environment now that there's things like handheld ultrasounds and simple tools like that to be able to diagnose and do more. There's a class on health leadership and promotion. So that's something that as a rural health physician, you're definitely involved a lot more in leadership, both in maybe the hospitals you're involved with, the community. You're seen as one of the people in the area that have a lot of expertise. And so that's something that you get heavily involved in. Also, there's courses, part of that elective, on things like wilderness disaster medicine. I know that I spent a great deal of time in the areas that I was in dealing with just kind of bizarre farming accidents and things like that would happen, or people on 4-wheelers up in the mountains, or those sorts of things were pretty common. So you have to learn to deal with those situations. And then we also have an advanced case discussion elective. So there's several electives to choose from, and essentially to be qualified as a rural track participant in your first 2 years with Noorda, you would need to take 2 of those 5 courses. They're not long courses, but they are to just introduce you to the concept. And then in your 3rd and 4th years, we have essentially 7 required core rotations here at Noorda. And 2 of those, a primary care and an ER elective, would need to be done in a rural setting. And we have those set up in Utah as far as hospitals that have agreed to work with us on those. But it also could be set up really in any rural environment and something, because I know some people that are familiar with this maybe come from a rural area and perhaps wanted to be able to do like their ER rotation in their home hospital. That was something that could be arranged and worked on, but we require, so essentially 2 rural rotations, core rotations, and then 2 classes during your 1st and 2nd year in order to qualify just as and get accredited, or I guess a commendation as a rural tract graduate. So those are kind of the basics of the rural tract here at Noorda. Those classes, will obviously have things like guest speakers, in the way that we do lectures is they're via video. So it may include a lot of different people that are teaching and participating from the outside in different rural environments that help to teach those courses essentially. but it will be facilitated and coordinated here on campus by one of the faculty here, including myself. So that's kind of the basics. I don't know if there's any questions on just the basic track stuff before I get into, I don't know, more what does rural medicine mean? Perhaps if there's any questions on rural medicine track at Noorda, if there are any yet, I'd be happy to field those.
So it looks like we don't have any coming in yet. So if you want to just kind of dive more into what is rural medicine, what does that look like? And then
and this is where I'm hoping to spend the bulk of the time anyway, because just describing our course and how to get there is one thing. But if you're a pre-med student right now and you're asking yourself, wow, is rural medicine something that I might be interested in? Just as a little bit of background on myself, I did not personally grow up in a rural setting. A lot of physicians that do end up in a rural setting, perhaps they grew up there and they know how wonderful it is to live in those settings and be involved in communities and that type of thing. My dad and mom both grew up in very rural settings, and the place that I went to work is a little town called Gunnison, Utah. It's a wonderful, amazing place. And although I didn't grow up there, I have ancestors for several generations that did. So that was somewhat my connection to that area and the way that I end up getting connected. But rural medicine, if you were to describe it to someone that doesn't really understand it, is I would call it everything medicine, meaning that you are actually involved in everything. So a typical workday for a rural physician, one of my wonderful colleagues down in Gunnison today, somebody is working in the emergency room and then they're running over to their clinic, and then perhaps they get called in to deliver one of the babies that they're doing. They would do that via C-section or via vaginal delivery. They're trained to do both of those things. They might run over and help run a code in the hospital and admit somebody to the hospital. In that same day, they might run over and do nursing home rounds at the nursing home that's available. Maybe they're a hospice director or something of that sort. So you're just involved literally in everything. I think the classic thing to call it is kind of from womb to tomb medicine, where you're involved from the moment somebody's conceived until the moment that they die. One of the most beautiful things about it for people that are interested in really developing amazing relationships with your patients, you typically end up taking care of multiple generations of families. So you're dealing, at the same time as you have somebody that's 95, you're also dealing with the great-grandchild. You probably delivered that great-grandchild. And so the whole family would come to the hospital, and it was just the sweetest thing ever to be able to, you walk out in the hallway and even though you have to be careful because of HIPAA requirements not to share too much, it's all just a big celebration. You're part of the family, you're part of their life, and it's just an honor to work in a setting like that. Now, as I say that, it's also a challenge because of those same issues, because you are connected with that community in so many ways. You're taking care of the next door neighbor or someone down the street that you know very well is the teacher for your child in school, but also maybe is having severe health problems or drug and alcohol problems. So you have to deal with cross-cultural and ethical issues. Quite frankly, I loved that part of it. I loved having it be my neighbor 5 doors down or whatnot that was in the office with me struggling and trying to work through a liver issue or a kidney issue or cancer or whatnot. The other thing that I kind of jotted down to highlight for people, one of the beauties of rural medicine is that really the patients, you are their only sort of entry into the healthcare world. So what that means is instead of going to 5 different doctors for 12 different things and picking and choosing, they come to you. You're definitely what you would call a medical home. And they come to you with a problem, and maybe you can solve it, or maybe you need to help refer them to a specialist. But when you do, it's a very serious decision because it means somebody's going to need to travel quite a distance. You're going to have to take the time for them, to take off work and to go up and talk to another physician. But the beauty of it is, as I practice down there, is you would perhaps send them to a cardiologist to get an evaluation done, and they would come back to your office and say, hey, I went to the cardiologist and they told me X, Y, and Z. And what do you think, doc? And they would literally involve you in that decision. And so it was a shared decision making. And I truly love that about it. And I will kind of, talk about versus doing medicine more in an urban area. Perhaps you do that same referral as a primary care physician off to the cardiologist. You might not see the patient back because they just continue to go to the cardiologist for whatever you sent them for. So it was a real difference. You're truly involved in people's lives. but I do recognize that it's a plus and minus. The other thing that students ask me a lot about is, well, what about the hours? Is that even doable in a rural setting? And the reality of it is, it's a 24/7 job. And as I think about my friends and colleagues and other people around the country and the world, for that matter, that do rural medicine, my hat's off to them. It literally is a job that is all the time, every day, everywhere you go. And I'll use an example that I use often with people. As in most small towns, the small town that I worked in had a couple little, drive-in places that are probably too good of a hamburger and fries, and everybody there. And I remember pulling up to the window. I had recently just started there, so I didn't know this was going to happen, but I placed my order and I drive up to the window, and the gal that I don't even really remember that much because I was brand new pops her head out the window and says, "Hey, doc, how you doing?" and asked me questions about changing her birth control. I mean, we had that conversation right there in the drive-in window, and nobody thought anything of it. For me, I was shocked. Like, what do I do? How do I deal with this? But you started to learn that you're just a member of the community. It's not just doctors that happens to. The local guy that is the police chief or the school principal has people hit them up for issues everywhere they go, walking down the street and at church or on the sidewalk or at the grocery store. So you're just part of the community. And that is it's such a beautiful thing. I can't even begin to describe what an honor that was. But at the same time, it's a big responsibility to be responsible in that kind of a way, with that kind of trust and whatnot that people give people in that sort of setting. Now, one of the things that I wanted to contrast that to was sort of, there are different sizes of rural medicine. Meaning you might truly be out in the wilderness of nowhere in Alaska, where you're, an 8-hour plane flight by the time you get to the airport and whatnot, away from something. Or you might be an hour away, where an ambulance can take someone to a tertiary care center in a big hurry. So there are different types of rural medicines, and there's probably one to fit everyone's personality. It's something that, although it is very demanding and at the same time, it's rewarding. It's also something that you can find available, meaning there's a lot of small communities around the country that are looking for a physician. And you sort of can get a kick out of, I know there's some classic movies that have been made over the years. I'll probably date myself by thinking of like Doc Hollywood back in the 1980s, but there's always movies talking about small towns trying to recruit physicians is very difficult. And that's a truism today. Across the country, rural areas are in desperate need of someone that wants to come and care for and take care of them. So if it's something that you're kind of interested in, the answer is yes, the jobs are available. And there are ways to get connected. There's ways to get loan forgiveness. There's ways to get school. You can either be employed or do your own thing. So there's a whole bunch of options when it comes to rural medicine. There's less regulation, which is a thing that some people really, really love, meaning you don't have to quite worry as much about whether your person took that insurance or this insurance, because you're the only thing in town. And so it's a little bit easier to get credentialed and those sorts of things with insurance panels, because there's literally no competition around you. But it's an honor. You end up working, the teams you work with are absolutely phenomenal. I would say the nursing staff, for instance, at the hospital that I spent so much time in, there's not a greater nursing staff as far as I'm concerned than Gunnison Valley Hospital, where I spent so many years. They're the greatest people that I know and are a huge part of the healthcare team. As a physician, you're just literally that small little dot trying to help. But they are there and they're with you everywhere. You work with them in the ER, and then they run back and deliver a baby with you. And then they run into surgery and do that C-section or DNC or whatever you're doing. It's the same people everywhere you go. You are literally a healthcare team. And I love that aspect of it. So that's kind of the spiel that I had prepared, but thrilled to death to go with questions or go into more details of anything that I've mentioned.
Okay, we have a couple of questions starting to come in. So the first one, you kind of talked about this a little bit, but maybe share a little bit more about it. The question is, are there pre-designated areas through Nordicom where students can go for their rural medicine rotations in this track?
Yeah, there are. It's a great question. I know that's a big deal for Noorda in general, as compared particular to a lot of osteopathic schools where you have to set up all of your own rotations. We have some places contracted right now that are willing to take students for those rotations that I mentioned, both ER as well as primary care. And there are several more physicians that I'm aware of that are willing to take students who haven't signed up officially with us yet at this point, because we're just starting out. So the answer is yes, those are places that we have. They are here in Utah. They're actually close enough to campus that you could, if you wanted to, even during that rotation, you potentially could commute, although it might be easier to stay a little closer. But one of the facilities is only about a 45-minute drive, and the other one is just a little bit more than that. So they're not all that far away to get to what we consider to be rural medicine from here.
And we have right now, for those who are familiar with the area, we have rotations in Price and Nephi. And then are those other doctors kind of in those same areas, or would we have opportunities to potentially branch out to different places?
They are. There's actually a potential to branch out. So in addition to those two hospitals that you just mentioned, which are both community-run based hospitals, and there are, I think, 5 total community-based hospitals. There's one in Gunnison, there's one in Moab, so in Monticello, and the ones that you mentioned in Price and Nephi that we've already contracted with that are a little bit closer. But the other ones aren't that far away either. Our big hospital system here, Intermountain, has several rural hospitals, also in kind of the central Utah area. So it's not like you wouldn't have to go far, but let's say somebody wanted to go down and find a place in near Moab or one of the other places. Those are certainly possibilities that we could look into. The ones that we're contracted with right now are the ones that are fairly close to our facility in both Nephi and Price.
Awesome, thank you. Okay, Eric is asking, is there like a rural residency or specific like residency training in rural medicine, or are there, I guess, maybe rural or residency programs located in rural locations?
So fantastic question. And it's sort of almost a threefold answer. So currently in Utah, there is not a specific residency that is nothing but rural medicine. Those do exist in the Intermountain West and around the country, where there are a couple places where you can go to essentially a family medicine / rural residency. However, part of what we are doing as Nordicom, and I'm actually thrilled and proud about this, is we're trying to get additional residency set up, not just in family medicine and rural, but we're also trying to do several specialties here in the state. But one of the conversations that's happening right now is how to set up a rural residency, because it's such a big need in the U.S. But I have friends and colleagues that I worked with that trained at various programs in the Midwest and in the West that trained on rural tracks in their program. So similar to a track like we're talking about with medical school, their residency would have a track. Now, most of us, especially when you go into primary care like family medicine, there's a couple of great family medicine residency programs here in Utah that turn out a lot of rural physicians, because you can get involved in things like a lot of deliveries of babies and emergency services and a lot of things that you really need in rural medicine. They're very conducive to and have sort of tracks or mini fellowships that you can take to emphasize rural medicine. In my own personal training, once I decided that I wanted to go rural, for instance, I was able to work with my preceptors. I did residency here locally, and the preceptors were so welcome, because essentially what they know is if you're going to rural medicine, you're going to be calling them on a regular basis. Let's say the NICU, the NICU, neonatal intensive care unit providers, when you deliver a baby and something happens to be going wrong because that baby's too early or whatever problem, they know that you're going to be calling them and consulting with them and taking care of that baby for hours and hours while you're maybe waiting for a helicopter to get there to do the transfer up. So they are crazy interested in training you correctly and helping out a lot. So residency for people that want to be in rural is not a problem. There are choices, but I think I want to emphasize that we are trying to also create extra and additional choices through our efforts here at Noorda.
Okay, awesome. And along those lines, are those residency programs the same length as, like, say, a typical like family medicine residency, or would they be longer because of the additional?
For the most part, yes. They would be a 3-year family medicine residency program. But some programs do have what's called a rural fellowship, which could be a year after you wouldn't have to have that qualification in order to work rural, but you certainly could have. Now, the other thing to be aware of, some of these places that are rural also have other physician job besides family medicine. For instance, down in Nephi, one of the places that we're contracted with to do rural medicine, they have an orthopedic surgeon and an orthopedic surgery department that works down there. And it obviously referrals come from all communities in a wide distance around because there's not enough population, but they're able to attract that. Or some of the folks that work in Price or Gunnison or whatnot only work emergency medicine. So there's different training programs that potentially could be available. It's not just a family medicine exclusive thing. There's no question that's the majority of the physicians in a rural setting, but surgeons, general surgeons are a big need in those rural areas. So there's other things that come into play when you talk about rural medicine besides just the one person that can literally do everything. That's maybe needed the most, but it's not the only need that they have.
Awesome, thank you. All right, next question. When does one need to declare an interest in, say, the rural medicine track or maybe one of our other tracks if we want to just kind of go general with the track on that front? And then along those lines, is the rural medicine track limited to specific specialties or for people interested in certain specialties?
So because it's such a quick answer, I'll answer the last half of that at the end. So regardless of what specialty you potentially might be interested in medical school, you are welcome to be in a rural track. What we also know from being involved in medical education for a long time, either by being in it or participating in other ways, people change their minds. So if they're interested in being a neurosurgeon, but they can still do the rural track in medical school because medical school is just a core education. It is not a specialty track to start with. So doing the rural track would simply just give you that extra perspective. Certainly for people, to answer the first part of your question, people I'll use the word declare that as soon as possible. It's almost like saying, if I was going to do a major in college, should I declare that sooner or later? And I suppose the answer is, as soon as you know it, that would be a great thing to do, but there's no rush. You might be able to just fill the generals. The way that we have the program set up at Noorda, and this is true for the research tract or the rural tract or whatever you want to talk about, but the sooner you do it, the more of an opportunity you have to be involved in the first 2 clinical years or the first 2 academic years here on campus. So I would encourage people, if you think you have an interest, to potentially sign up and get involved in the interest groups and those sorts of things that we're trying to get set up. But it's also okay if you get to your second year and say, hey, I really might want to do this. The other thing that people might have, well, what if I don't do the rural track? Can I then not do rural medicine? And the answer to that is no. The rural track just gives you an extra, but is not a requirement in order to go into those jobs or those residencies. But it certainly would give you sort of a leg up in residency to have a credential like a rural track if you were trying to get a residency that did rural medicine. So it just gives you an extra leg up. It's an extra thing. It's not seen as a required thing at all.
Awesome, thank you. All right, kind of along those lines, you mentioned like interest groups and that sort of thing. So are there or will there be student or community organizations dedicated to rural medicine? For example, if a student wanted to learn more about rural medicine, but maybe not quite dedicated to the rural track just yet, would there be opportunities for them to learn more about that?
There are, both on campus and off campus in wider community groups. On campus, we are just in the process of starting our first rural interest group. And we just did kickoffs for groups last year with our first inaugural class. So it's kind of fun to just get those things going. But there will be a rural interest group as well as most other groups you can imagine, whether it's primary care or a specific specialty or whatnot. As we have students that are interested in those, we're happy to create those and get those going for students. But more on a broader basis, most of the primary care groups, both nationally and in state organizations, have I'll call them rural interest groups. So for instance, the American Academy of Family Physicians, if you go to national meetings, there's a rural interest group that you could be involved in. And in our state level, the state section of the American Academy of Family Physicians also has a rural interest group section. And in fact, if students know they want to do this and sort of sign up really early, that state organization will be heavily interested in you and want you involved because they want you to hopefully end up there, which may include being involved in their meetings, and maybe even getting some free handouts and whatnot if you're involved in that, because they're trying to encourage people to be in rural medicine. And then you think more globally than that. Rural medicine is something that we're have a shortage of in the US in general. So there's a lot of national organizations, National Health Service Corps, and a lot of other ways that you can end up getting school paid for or getting loan forgiveness if you're willing to declare. Now, those things that are involved getting things paid for obviously involve much more of a commitment than just an interest group on campus where you don't have to commit to much of anything other than showing up and having pizza. But the places that are maybe doing loan forgiveness, you need to commit yourself to being willing to go for a certain number of years in exchange for a certain amount of pay.
Awesome. And you have some experience with the National Health Service Corps, I know, right?
National Health Service Corps is something I'm very grateful for personally during the years that I worked down in Gunnison, Utah area. For those 5 years, 4 of those years, I was on the National Health Service Corps Loan Forgiveness Program, which essentially was in exchange for me being there in that area. The National Health Service Corps paid a certain portion of my debts. The more that people are willing to commit and the longer, obviously you can get more and more paid for. But the way that medical school debts are, it's a fantastic way for those that have any interest at all to help get some of their education paid for. I had a very good friend that during medical school signed up. So he signed up really early on and actually had, sort of a scholarship essentially that he was going to medical school on because he was willing to commit. And then after medical school, he ended up, going to Guam and Hawaii. I mean, the poor guy had to do rural healthcare in Hawaii. And so there's some great locations. Sometimes we think rural medicine and I don't know, you think of a swamp infested mosquito area, but I can tell you from my experience, it's just a beautiful, wonderful community. And I think most people around the country would agree with those sayings.
Yeah, that's awesome. I think it's a great opportunity for the right person. If you're genuinely interested in rural medicine and ready to commit to, give some years of your time in those areas and get rid of some debt, I think it's a good option. So along those lines, because I said for the right person, yes. What do you think, because it's not for everyone, right? If you need to be able to run to Walmart in the middle of the night in 5 minutes, rural medicine and a rural area probably isn't going to be for you. So what would you say, what are some of the characteristics maybe that would make someone a good candidate for a rural medicine track or a career in rural medicine?
That's a great question. And the number one thing, and I know this is a little bit vague and I'll talk about more specifics, but the number one thing is you have to, in some sense, be a people person because you are not just going there to be a doctor. You are going there to be a community member. And that's a big deal when you commit to these rural areas because they do need your resources. And you're going there to really be involved. And like I say, I wouldn't say anything different of somebody that was being a high school principal or whatever other job. You are it when you're that kind of job in a small community. So you need to be really committed to the fact that you're willing to be a people person and love those people that you're around because that's a big deal to them. The other thing that deals with that is I mentioned, for instance, taking care of multiple generations. You have to be somebody that's interested in that and that thinks that is actually a fun part, that you know your patients very intimately and you're not, I'll use the phrase, just their doctor. You are much more than that. You're a friend, you're a neighbor. You do a lot of other things with them. And there is this difficult part of you still have to keep a distance and there still are HIPAA regulations and all those kind of things that govern behavior and what we can do. But there's a much more stronger bond than just physician-patient that develops in those rural areas. So that has to be something that you actually are interested in. For somebody that isn't interested in making connections with people, I wouldn't recommend it. It's not something that I would go spend a lot of effort and energy on. The other thing is, you kind of mentioned some of the practical side of life. Most of these rural areas, a lot of them will have, I'll say, access to, say, like a Walmart, but it might be in the next town over. It might be 15 or 20 minutes. It might be 30 minutes. Most of the local areas that you would go to would have a local grocery store and post office and banking somehow. But the days where you're totally isolated, you still can find them. They're harder to find. And places, have become a lot more together because of, internet resources. You can still shop on Amazon the same as you could shop if you're sitting in, any other city in America. But it's a little bit, maybe you wait an extra day for the delivery. But the good part is probably nobody's going to essentially steal off your porch. And if they do, half the world's going to notice. We had somebody take a package off our porch down in Gunnison that we had ordered from Amazon. And that became an issue really quickly. Sorry about the lights. They just went out on me. So
you must not be moving enough.
Trying to move. Hello. There we go.
There you go.
Back. But as I was saying, there is a practical side. The other thing is some people worry about, well, what about, if I have a family or children? When I made the decision to go rural, we have 5 children, and they went with me through medical school and residency, and that's a whole other story unto itself. But so we moved them into this small town, and small towns are just lovingly accepting if you are willing to love them back. And my children, for instance, had just phenomenal experiences during high school years and that sort of thing to be involved in a community setting. So there is a way to do that, even if you have concerns. But if you're not totally bought in and it's not something you want to do, I definitely wouldn't, because there's a sacrifice involved as far as not having access to urban things that you may want to be able to do.
Awesome, thank you. Okay, so you've talked a lot about how this is kind of a 24/7 job. Not kind of, it is. So with the rural track, or maybe just at Noorda in general, are there some resources or some maybe additional discussions or something like that, if you will, to around the idea of like avoiding burnout for some of these 24/7 type positions where you could literally be working all the time?
And that is a huge issue throughout medicine. There's no question. And a lot more resources now are paid attention to this than before. And it starts in medical school, like places like Noorda. Now we have a wonderful and amazing wellness program that you have to be involved in. Now, the further you get out in rural medicine, the more 24/7 it becomes. And so it is a real issue to be able to find some time and some ability to learn how to both do coping skills as well as healthcare for yourself, whether that be, taking time for yourself and those sorts of things. And I think physicians as a group, we're terrible at that sort of thing. We don't do that very often in the place where I was working. And I know I have colleagues that are down there now that they almost literally are working 24/7. They're in the hospital most of their lives, but you don't have to be. There's also ways to work around it where you start to share call responsibilities, where you start to share the ability and use remote medicine more and have, the urban areas tied into your ER, or maybe now that there's telehealth, helping patients to go through a telehealth avenue. And when you do that, then the trick is to actually take the time to do some things to help yourself overcome burnout. And I'm not going to pretend that I'm an expert at this because that's something I've gone through and experienced myself. And so I'm also going to knock anybody that is in the middle of that sort of thing. It's difficult, it's challenging. But I think, as I worked recently as the chief medical officer of the largest specialty group here in Utah, and I found that same level of burnout in the urban physicians. It's just people, you really can get sucked into medicine and feel really good about it because you are helping people. And so you try to say, well, that's my anti-burnout, is just helping people, but that itself you can get burned out from. And so you have to find a way to be able to step back. And whether that's through friends or family, or you're as lucky as I am to just have an amazing spouse that you can talk to and spend time with, there's got to be a way for you to be able to get out of that world and into the other parts of your life to have good balance. And I think that is tricky in rural healthcare. But the honest truth, after working with a lot of physicians here locally, is it's also tricky in, I'll call it, I guess, urban healthcare, if that's the opposite of rural. That's just a challenge in medicine, because we have this expectation that our physicians are always available and can take 5 hours for that surgery, even though maybe they haven't slept in 3 days. I mean, those become real issues. When I served my time, I shouldn't say served my time. Holy cow, it makes it sound like a jail sentence, and it wasn't. It was my choice, and I loved it. But when I spent my time in rural medicine, there were days upon days upon days where sleep was almost zero. But the reality of it around, because it was such a community focus with the nurses and others, they most of the time knew that I was really struggling and needed sleep and would do anything to go out of their way to say, hey, why don't you go back in, room 15 and grab a quick nap, and I'll cover this patient. I promise to call you if there's a problem. And you get a lot of things like that, or the great people that are running on the ambulance service would kind of say, hey, we'll take this for you. We can do this. You don't have to go to this today. And so there are amazing people around if you're willing to let people in and help you. But that is a challenge. I think that's a challenge in medicine. And if you're going into medicine as a pre-med student, you need to go in with your eyes open, that this is something that essentially you are doing somewhat as a calling for humanity. But to do that, you've got to somewhat protect yourself and learn how to give wellness even while you're still performing this calling.
Awesome. Okay, can you talk a little bit, you talked about this a little bit, but maybe go a little bit more into it. Some of the things that rural medicine physicians deal with that maybe the more urban physicians don't deal with as much. Like there's some logistical things. You have to have some additional administrative kind of training probably because you're managing your practice because you're it.
There is. I mean, great question. So when you get out of residency training, regardless of whether it's primary care or whatever, I know you think you're ready to be a physician. That's about the time it hits you and you're about to pass out, because literally all that means when you finish residency is you no longer have any help. So you're out on your own. You show up in a rural place, and I'll use my example, and I don't think it was extreme or that anything special. When I showed up down there, I certainly knew I had my own clinic that I needed to start running and getting patients. And there was a local physician there that was retiring and slowing down. So I think in general, we all just assume that, well, all the patients will go from that person to that person. And the truth is, that doesn't exactly happen like that, because people have different personalities. Maybe people that loved him for years thought I was a little bit weird, and vice versa, people that have been going elsewhere. So there's this shuffling and this and that's a little bit difficult politically, I guess is the right word to say, as people shuffle around between physicians, and you just have to learn to respect each other. But you mentioned things like being ready for other positions. I also found out, I guess is the best way to put it, that I was going to be the hospice director there for that community. I also found out that I was going to be one of the chair of the OB department. I found out on the first day that I had OB call that day, and that night I ended up having somebody come in that didn't have a physician, and I ended up doing an emergency delivery in the middle of the night by myself. So you're thrust into responsibility that I think you could say, well, I at least had some background in those things. And I would say, well, no, not really. I had only dealt with hospice with a few patients during residency, and I had maybe had a couple lectures about it. And suddenly I was a hospice director. A year after that, I was asked to be the nursing home director. Sometimes you're asked by the health department, hey, can you come do an elementary school presentation on pediatrics or vaccines? And so you really end up playing a lot of roles. I found it truthfully to be thoroughly enjoyable because it forced me to go and learn a lot of different things. And I was grateful for medical resources that we have available at our fingertips through the internet, so I could go learn about what are the responsibilities of a hospice director. And today, if somebody went to that community, the reality of it is they have a well-trained hospice director there now, so they don't need it anymore, because in a rural community, it just depends on what they need. And a lot of times they have somebody that'll be in that job for years and years and do a great job. But then you show up and all of a sudden you're thrust into, you're the chief of staff. After being there for a couple of years, I was the chief of staff and on the board of directors of the hospital and trying to figure out how to participate effectively in those roles. So to me, it was, I guess, fascinating and enjoyable, but I see how that also could be scary and overwhelming if you didn't recognize what you were getting into the middle of. But to describe it in fairness, again, if I use the high school teacher or the person that runs the convenience store, in those sort of communities, they're also the people that are asked to be on the city council or the city planning commission. When you go to a rural setting, you take on more roles than just what you think you're due in life. And if people don't participate like that, the community can't thrive. So it's part of just going to those places and understanding In some respects, it's marvelous and wonderful because you can get involved in anything you want. If you want to go help coach the high school football team or be involved in the local play as a helping them with the choir or whatever, you certainly can, because they need resources for that kind of thing in rural settings. So you can do a lot of maybe your interest or hobby areas could be an effective help to others. But your leadership in medicine would have to be part of it right away. You would have to jump in and realize that you're a licensed physician and they need that, and they need that in a lot of different roles.
That's awesome. Thank you. Okay, so we have a question from Facebook regarding the standard of care and how that compares in rural medicine to maybe urban medicine due to maybe lack of equipment, lack of team members, treatment capacity. How is that impacted?
Fantastic question. So when you look at things like standard of care and how that's affected, when you get into a small little area, there is no question that you are going to be affected by resources, and that can be people resources, could be the physician, could be nursing, could be a respiratory tech, could be anesthesia. There's a whole bunch of roles in medicine. So if you are missing one of those key roles, you're not able to fill that very well. The simplest of things, we take a lot of jobs in healthcare for granted, whether it be a rad tech to come take an x-ray or do a CAT scan in the middle of the night, or to somebody to be able to make sure that there's the meals prepared, and the pharmacy to be able to make sure that there's every kind of medicine needed. There is the potential in a small area to have a lower standard of care given. The reality of it is, you would be amazed if you haven't been to some of these places to see how amazingly prepared they are. They really do usually have incredible people, but the problem is if that one person is missing, then there is a hole in the system, because that might be the only person that knew how to do that around. So every rural area needs to have amazing access, whether it's via life flight transfer, ambulance systems, remote call-ins. I know here in this state, there's a lot of outreach done by the larger hospital systems to help the rural settings, to be able to get that NICU doc on the phone or on the equivalent of a FaceTime immediately so that they can help you evaluate that brand new baby that's in real trouble. So those kind of resources, now that we live in an age where things are more available, also make it safer and better care in a rural environment. Now, the reality of it is, for the most part, as far as legally, they're held to a very similar standard of care. And what I mean by that is they are not the ones, of course, that's going to put in a heart stent for you if you need that in a rural setting and you're not an interventional cardiologist and don't have the staff around you to do that. But you are going to be held to that same standard of getting someone and recognizing the problem and getting them to the appropriate care as expeditiously as possible. And that becomes one of the real challenges of rural medicine. You face all the time the decision of, do I life flight this person? I know that's going to be a $20,000 or $30,000 cost to this family who you know can't afford it. Or do you send them by ambulance, which is much less expensive? Or do you keep them in your own hospital? And that's a standard of care that I would say urban physicians have no concept how difficult that decision is. That decision is incredibly difficult to try to make sure you know when that person has to spend 30 grand on a life flight or whether they can sit in your ER and be just fine, because it's not always black and white. And so you do spend a lot of time communicating with other colleagues. Like I say, for the people that do this long-term, the most incredible physicians and other types of providers that I can imagine, because they can make those decisions of literally life and death, whether or not to spend tons of your money in a moment's notice and be accurate most of the time. And so they are held to that standard of care. But there's no question, if I were to, I don't know, you would say, well, where would I rather have a stroke happen? Would I rather it be in the middle of a rural place or in downtown where there's a hospital on the sidewalk I happen to fall on? Well, of course, you'd rather be closer to the tertiary care center. But I can flip that around. If I'm living with a long-term disease and I really want my physician to care about me, to love me, and to be part of my decision-making, then I think it's wonderful when you know that physician. He's your neighbor. He cares about your kids. He knows your family. So there's some pros and cons that come with this. The standard of care, the urban folks can never meet the caring as far as my perspective is. But the rural folks can't meet the facilities and the other specialists you have around in a rural setting.
Awesome. Okay, you kind of talked a little bit about resources and kind of the lack of resources that these folks that live in rural settings tend to have. Is there additional training for finding resources and helping connect people to them, almost like a social worker would, if something like that isn't available in the area? Do rural medicine docs do a lot of that?
So yes and no. You just mentioned one of the just absolute key members of a healthcare team. There's no question. As a social worker, especially in kind of those tertiary or community care kinds of settings, to help you find resources, to help families know how to find resources. And if you have a really good social work network around you, in a rural setting, you're totally set, because they, just like you, are working 24/7, and you can just call them at home and say, hey, I've got this issue going on with this patient, and they will jump right in. And I was very fortunate in the area that I was in that we had just an incredible social work. He was over our area, and then he had partners that would help out. And I'm just still amazed at the things that they were able to do. And they also did full scope, because they're working the ER and out with the nursing home and hospice, and they're doing everything too. But some of the communities that I know of that don't have those resources, essentially it becomes sort of a telehealth sort of a situation. And that is much more difficult. And so the physician will spend a lot more time themselves, perhaps calling around and being their own secretary and their own everything else. You don't have anybody else to go do those sorts of things. If it's the middle of the night and you need to transfer somebody to a different hospital, you can do it yourself, just as easy as you can ask someone else to do it. So there is a lot more taking on responsibilities that others may or may not have as you're going through those different decision-making times. But you do, for the most part, have at least telehealth access to most of those resources. And most communities that have at least a local community hospital do have, because of credentialing requirements, their own access. They'll just have one maybe, but they will have someone around that can help with those things.
Thank you. Okay, are there opportunities for physicians, say, that want to live in a more urban setting and have kind of that experience, but maybe take call or do some shifts in rural settings? Is that doable? Do physicians do that?
For sure. And some physicians do it quite a bit. So some physicians, and I think the classic example of this would be ER physicians that perhaps will just work rural medicine and then live somewhere else. And they'll go and work, 3 shifts in a row or something like that, and then have a week off where they do whatever they want and live somewhere else. Some of the communities depend upon that type of thing. I don't think any small community necessarily wants that, because they'd love somebody to be part of their community and be more involved. But it becomes something that people depend on. I know a lot of physicians up here that essentially what you just described as sort of moonlighting, maybe once or twice a month, they'll go work in a rural ER somewhere. And sometimes it's in different states. I know folks from here that go up to Wyoming and out to Colorado and whatnot and do shifts, or they go more to central or southern Utah and do shifts. So there is that available. And some people do that. On the specialty side, it's done even more often. There would be specialists, let's say cardiologists I know who work here with Revere Health, or orthopedics, or the oncology groups. They do outreach clinics. So even those specialists, perhaps they do 4 days a month or 2 days a month where they go out to a rural setting and run clinics. And that way, those people out in those rural clinics don't have to travel so much. And so that's a way to be involved in rural medicine without actually having to jump in head first. Or if you have a different specialty, it's also a way to be involved in rural medicine and participate in that a few times a month. A lot of them drive with their whole staff, and they'll just take out and rent a clinic for a day, and they'll do that 2 or 3 times a month. And that's a great service to some of those communities. It really helps patient care, makes it so those patients don't have to take so much time off of work to see them. And those things are happening all across the country. And so that's a way to be involved in rural medicine in a really, really awesome way.
Okay, let's kind of circle back to the rural medicine track a little bit. Can you talk a little bit more about the opportunities to get experience with wilderness medicine? We've had some students interested in that specifically, and you kind of mentioned that there's a course on that.
There is a course, Advanced Wilderness Life Disaster Medicine. And that's something that a lot of people do have an interest in because maybe they're just into hiking or outdoors. And so that goes way beyond rural medicine. And certainly those wilderness training courses are something that are available not just to somebody that's interested in rural medicine. Those courses that I mentioned, for instance, for the most part, will be open to any of the students. It's not like you have to be a rural track in order to take the health leadership or the advanced wilderness life support class. You're able to do that otherwise. And that's true after you become a physician and after residency also. I could go take additional training in wilderness medicine at different courses that are offered if that just became an interest area, or I wanted to learn about avalanche medicine, so those kind of things are available. And they do start during medical school, but the reality of it is they become much more relevant the further along you are in training, in residency, or afterwards, because then not only can you kind of learn about it, but then you can actually go practice it and go out and participate as a physician when you're doing your hobbies, or if you want to be part of being a medical director for a national parks or those sorts of things. Those things are needed and they are out there.
Ken, can you talk a little bit again about the requirements to join the track? Is it as simple as just saying, I want to do this, so I'm in, or
yeah, it really is. So
that?
There's I guess there's a form to fill out because that's life with everything, right? So you would, you'd put your name on it, and there's a little form that we have here at Noorda. If you were a student here right now, you would fill out the form and it comes to me. And I'd probably contact you to say, hey, why do you want to do this? So that we can just have a discussion. And the answer doesn't really matter. You might just say, well, I'm interested in those courses, and so I might as well do it. And I'll say, okay, that's fine. And we'll work through it. But so it's very simple. We're not trying to exclude anyone. It's not like you have to be committed to rural medicine for the long term. It just can be something that you might want to learn more about and have an interest area in. To get the credentialing here at Noorda, there would be, like I mentioned, you have to take 2 courses during your first 2 years, and then you have to do 2 of your core rotations, 1 in primary care and 1 in emergency medicine in a rural setting. And that can be those that we have set up, or those can be others.
All right, next question from Eric. So what size of a population is considered a rural community? Is it measured by county or city population? What's rural?
Eric, that's a great question. And so there are places, so for instance, with the National Health Service Corps, they have a population and physician per population ratio that they consider rural medicine in order to qualify for their program. Or they also include in their underserved. So a lot of people would say, if I work in an underserved health clinic where those people, because of financial and other resources, don't have access to specialty care, that is equivalent to roughly rural medicine. So if you're trying to be in a specific, say, loan program or a physician or a specific state program to get loan forgiveness, they will define it for you as far as what is rural medicine. But really, other than that, it's very soft definition at best. Because it really depends upon your perspective. If I took some of my physician friends that I went to medical school that are in New York City, they would tell me I'm a rural physician sitting here in any of the biggest cities in Utah, because they would have, you don't have anything there. So it all depends on your perspective. If you ask me, I think you need to be in a place that hardly has a stoplight. So that's how I'm going to measure rural medicine, maybe is by the number of stoplights you have in town, because we didn't have any stoplights. So I considered that rural medicine. But like I say, that definition can be very broad. But if you're trying to get into a specific program like National Health Service Corps, or there are some states that have programs and that sort of thing that help you pay off loans, they have very exact definitions that are based on both population as well as whether the community is served appropriately by the number of physicians or whether it's deemed underserved. So there's a lot of ways to split that. And so it depends on the specific program. Here at Noorda, like I say, to be part of the rural track, you just have to have an interest and actually do the track. So there's not like you have to be in the saying that you're going to be committed to go back to a town that has less than 20,000 people. That's not the case. You can do our rural track and then go practice in New York City if you feel the urge.
And you would actually get some really cool experience that
I would
maybe
argue that
could be translatable.
there is no better training on earth, because one of the things you also learn to deal with from a rural perspective, and maybe people understand this better when you think of wilderness medicine, is you just make do. So you figure out that you don't need every little instrument to be exactly like you want it. You learn how to do things out of a necessity of need, because you don't want to send somebody on a helicopter for something that if you just had a certain instrument. So you figure out sometimes how to make an instrument, or how to use two other instruments to be the one you needed, or whatever you need in order to get that piece of wood out of somebody's leg that hasn't hit an artery. Yeah, you figure out how to do it, and you just deal with what you have.
So it sounds like you have to be pretty innovative and be able to think outside the box and utilize the tools you have in maybe different ways than you were trained to use them. So
yeah, and for me, I mean, I'll just speak honestly. I didn't see myself as somebody that really was able to think outside of the box, or think creative was not a thing that people used with Steve Embley. But Dr. Embley down in Gunnison learned how to be creative. I learned how to do strange things in strange places, and it was just marvelous for me from a personal development standpoint, for me to learn that, wow, I can figure this out and use a different instrument or a different technique, or well, that you have to go without right now. We don't have that. So let's figure out a different way to solve the same problem.
That's cool. I like that. I'm glad we have you here, and your experience, your wealth of knowledge, especially in this rural area, rural track, rural medicine area. So we're about out of time, and I like to end these sessions with our guests sharing maybe a little words of wisdom or nuggets that our viewers can take with them. So what would you leave with our attendees today?
Wow, that really opens it up, all kinds of fun things. But given that our audience primarily is pre-med students looking at different schools and looking at Noorda, I'll try to speak to that from that perspective. I had the just great opportunity. For me, going back and doing medicine was a second career. I had chosen and gone down the path where I'd gotten my MBA degree as a full-time MBA student, and then had gone to work for many years doing other things. I was working with Intel, and like I said, I already had a family and those sorts of things. So medicine for me was a second career. As I was yesterday presenting to our students, we were kind of doing what we call a cycle review, where we are face-to-face and teaching some of the concepts that they're struggling with. They also had a test today, and they have a test on Monday. So it's this perceived high-stress time. And I would say the same thing to pre-meds. It's such a high-stress time, and you're worried about getting A's in every class, and you're worried about the MCAT, and you're worried about shadowing and getting letters and recommendations. And oh my goodness, you feel like the world's falling in on you. But the reality of it is, you need to have a legitimate purpose of why you're doing it. I know a lot of you will take the time to maybe look up on the internet, why am I going into medicine? And you try to give us those canned answers in an interview. To me, that's just garbage. It needs to be what you feel like. Why are you going into medicine? And the reality of, you're not going to sound hokey saying, I just want to help people, if it's real, if that's the true reason you're going into it. But then you need to understand, well, how does a physician help people? Because if people need help, let's say, I don't know, spiritually or some other way, yeah, you can help as a physician, but you probably ought to go into, being a social worker if you really want to spend time solving those kind of problems, and you'll add even more to society if that's what you're interested in. But for those that have a true love of this combination where science kind of meets human interaction, this is a fantastic place to be. And then when you go to choose medical schools, I get it that you want to have at least one school on your checklist that you can say, okay, I'm in, and you check that off. But you really need to look at the school that you're going to and see if it fits what you're interested in as a personality. For instance, at our school, it's a heavy focus on being able to be an adult learner and to be able to not have faculty in your face every single second of the moment kind of pushing you along, because we're going to let you study at your own schedule and go to classes in pods at your own schedule. So it's a very different environment. Now, for me, of course, I would answer, well, that's the best environment too, because I think this is the most incredible model of medical education that I've ever become familiar with. So I love this. But I also am not naive enough to think that this would fit every personality. If your vision of sitting in classroom and just listening to a lecture all day long in this large classroom, then please find a place that does that, because that's not what you're going to find here. But if you choose to go in and continue down this path of medicine, and you go through this marathon of at least the next 10 years of between medical school and residency and fellowship and whatever you're going to do, you better do it, and you better remain focused on your purpose. And if you do that, you'll love it. You'll have success do it. Yeah, you'll burn out sometimes. I have. Maybe you'll be way better than me, but and for the most part, talking to all my friends and colleagues, I doubt it. You'll probably go through ups and downs, but you'll be able to reflect back on the purpose of why you're doing what you're doing. It is an incredible opportunity to truly help others at a critical time of their life. Whether that's a great time, like delivering a healthy baby, or whether that's the worst of times, like delivering a baby that has already passed away or passes away shortly after birth. And every spectrum from womb to tomb, it is amazing to be there with people if you can truly care for them. So I would recommend it to anybody that wants to, that can truly have a purpose. But if you don't have that purpose in life and you just want to go earn some money, then I wouldn't waste your time, because there's a lot of other ways to do those sorts of things. Was that okay for closing?
That was fantastic. Thank you. I don't even want to say anything after that. I just want to end it and let that be the period on the sentence. That was fantastic. But I will say thank you for being with us, Dr. Embley. I appreciate you taking the time to share your experiences and your knowledge with us. And thank you all who are in attendance or who watch this in a recording later. Thank you for taking the time to look into kind of what we're doing here. We do have a couple of Faculty Fridays left this year. Our next one will be next Friday on wellness and interprofessional education. That's something we're doing a lot different here at Noorda, like most of the things we're doing here. We do have an integrated wellness program, and I'm really excited to have our Director of Wellness and Interprofessional Education join us next week to talk more about that. And then if you have missed any of the previous sessions, you can find recordings for all of those on Facebook Live, or on Facebook from our Facebook Lives. The recordings will be on there, on our YouTube channel. And then recordings are also on our events page, Nordicom.org/events, and you can sign up for all of our future sessions there. So thank you again for being with us, Dr. Embley. Thank you everyone for joining us, and we'll see you back here next week.
Take care. See y'all later.
See ya.
Record.